Hello, welcome all to tonight's webinar. This is the third webinar series of the Tokyo Valves 2022 in anticipation of the coming PCI Valves 2023 in February next year. I am Michael Lee from Hong Kong. Joining me, three other distinguished experts. They are Yohi Ono from Japan, Didier Chicher from France, as well as Kazu Shimamura from Japan. If you can remember, we have had two series of webinars before. The first webinar is on patient prosthesis mismatch and the relationship to durability and survival, as well as paravalvular leakage. The second series is on lifetime management of AS patients, in particular SAVA versus TAVI, as well as valve-in-valve specifics. Tonight, we are going to see how we can optimize the procedural outcomes of TAVI in our contemporary practice and to understand the current limitations of our TAVI devices, as well as learn how procedural refinements may in fact improve the clinical outcomes. You're welcome to participate by typing your questions, and this will be responsible to raise your questions, and we will all try to answer as many of the questions as possible. So without further ado, I would like to call upon Dr. Kazu Shimamura from Japan to present to us first a patient of a recorded case from Asia. Kazu, please go ahead.
Yes, thank you, Michael, for your kind introduction. So I would like to present one typical Asian patient. So let's start the slide. So this is a 79 years old female who has very severe symptomatic severe AS with heart failure symptom of NYHA class 3. And she also has past history of bronchial asthma, and her clinical fatality scale is 3, so it is relatively preserved, but this is a very tiny lady with a height of 137 centimeter and body weight of 55 kilogram, which calculates the body surface area of 1.38 square meter. The renal function and nutrition level is good, but she has elevated BNP level. And the predicted risk for a surgical AVR is calculated as a 4.7% by STS score. So this is a procedural echocardiography, and there is no conduction abnormality in the preoperative status with normal sign of rhythm. And when we look at the coronary CT, there is no significant stenosis in the both coronary arteries. And the echocardiography shows that she has a preserved left ventricular ejection fraction of 75% with a relatively small dimension of 33 in diameter, diastolic diameter. And the peak velocity was 5.2 meter per second, which is a very severe AS with a peak and mean pressure gradient of 110 and 65 millimeter mercury. The estimated aortic valve area was 0.5 square centimeter.
Okay, so if we, as I can see, I'm gonna continue, Kazuo. So here we can see this is a very, very challenging patient, we can see, and I'm really looking forward to hearing your discussion because we are not so used to these Asian patients with such small anatomy. So on the screen, you can see what are the CT more in-depth assessment of the annular dimension. And from the area-derived diameter, we get a 21 millimeter as the mean area-derived diameter of the aortic annulus. If you take the perimeter, it's going to be 22, so definitely a quite small anatomy. If we relate that to the sinus of Valsalva, we can also appreciate the dimension of the sinuses of Valsalva that are quite small. The maximum dimension is 27, and on average, it has to be about 26 millimeters.
Okay, Didi, thank you.
If we scroll,
I can see
yeah,
now
okay,
the screen. Yeah, I will
okay. So
continue. Thank you very
I
much
will
for
let
your
you continue.
support. Yeah, thank you very much. So the LVOT is quite small as well. Its perimeter drive diameter is 20, and the ascending aorta is 29 in this case. And when we look at the aortic valve calcification, which represents the very severe AS with a high volume of calcium, especially in the right coronary cusp and the non-coronary cusp. And the problem also shows that she has a small ST junction with a diameter of 24. And the coronary height is 10 in the left side and 14 in the right side. It's relatively low, especially for the left side, and the height of the STJ is 16. So absolutely, this patient has a small aortic root. The aortic root angle was relatively benign with an angle of 54 degrees. And despite the small size of the patient, she has a relatively good access. She has a good diameter in both femoral and iliac arteries, and the tortuosity is mild. And one important anatomical feature of this patient is that she has a relatively long membrane septum length, which was calculated as 5.5 millimeter from the basal plane. And we have estimated the predicted mortality in the long term of this particular patient using the three different Japanese risk models. And all the models predict she will have a very good survival possibility in 1 year. And even in the 5 years, she has a 60% chance for surviving. So this patient will have a relatively long life expectancy. So thank you for your attention and sorry for their computer trouble.
Thank you, Kazu. We will have some time for discussion, in particular on the aspect of conduction and amenities. Maybe I start with you, Yohi. Uh,
Sure.
you saw the patient. It seems that if you calculate the STS score, Euro score, it is not a particularly high risk patient. But in your opinion, what are the risks of this patient that will end up with particular complications, in particular conduction abnormalities?
Thank you, Michael. So, in terms of potential conduction disturbance in this specific patient, the patient has baseline no conduction disturbance, as Kazuo mentioned, no right bundle branch block. And the length of the membrane septum, as we measured in this case, was 5.5 millimeters, which is not too short. Previous literature has shown that membrane septum length less than 2 or 3 millimeters carries potential risk for new onset conduction disturbance. So in my side, this specifically for conduction disturbance, this patient has relatively low risk for new onset conduction disturbance. But the problem is the patient has relatively small aortic root, small sinus of Valsalva, and relatively low left coronary artery. So we don't want to implant the valve too high, which could potentially preclude the future coronary access. So this always would be a balance. Thank you.
Great. Thank you. Yeah. Didier, you mentioned about some sort of differences between Asian and your Caucasian population. So what difference can you make out of this case? And how does it affect the clinical outcomes of these patients?
So it's this is a very important point that you just raised, Mike. It's true that in Asia, from what I can see, is that you have patients with that are smaller than what we can see in Europe and Western countries in general. So the anatomy is smaller aortic roots with small aortic annuli and LVOT, and this may have an impact on the overall oversizing that we're going to apply when we select a device. So we're not going to dive too much into the hemodynamic aspect of the procedure, but if we focus on conduction abnormalities, I may assume that given the fact that we are in Europe able to treat patients with larger anatomies we put aside beside the hemodynamic aspect. And if we focus only on conduction abnormalities, maybe we have less calcified patterns as compared to Asian patients. Particularly, maybe you have more bicuspid patients that we have. And so this could impact the occurrence of conduction abnormalities because we know that if you have a high calcific burden on the aortic root and particularly in the commissure between the none and the right, this may increase the likelihood of a pacemaker requirement. So these are small but very important anatomical features. The overall size of the aortic root, the calcification pattern that are going to impact the valve size, the valve selection, the valve size, and potentially the technique, because I like the comment from Yoe stating that it's not only about the matrix of the patient, is about integrating all the risk. And if you have a risk of coronary obstruction, sometimes you need to put the device a little bit lower, and as a consequence, you're going to increase the risk of pacemaker. So these are the differences that I can see between Asian and European patients, and this may provide subtle differences as well in terms of technical procedural steps.
Oh, thank you, Didier. So, although we can see the membrane septum of this patient is not short 5.5, but in any case, we still need to get a high implant in order to decrease times of pacemaker requirement. But as we can see in this particular case, small root, small annulus, small size, as well as quite, I would say, quite a low coronary of 10 millimeters. So how do you balance between coronary obstructions and conduction abnormalities in this particular patient?
Yes, it is a very good question. So as already Yohei and Didier had mentioned, we have to make a balance of the both risk of coronary obstruction and the risk of conduction disturbance. So this particular patient has a relatively long length of the membrane septum, so it will allow us to make a little bit deeper implantation of the device, and that will be good for the coronary obstruction risk. And also what we have to take care is the commissure alignment of the device. So if we put the device commissure in front of the coronary arteries, it will disturb the coronary axis. So maybe the implantation depth and the alignment of the commissure would be the key factor for this case.
Right. That's a real challenge. Um, so you here, since you know the case well, what other parameters would you consider to decrease the chance of conduction abnormalities in this particular case, apart from the cups overlap technique?
Yeah, thank you, Michael. So um, we will see the cusp overlap technique in this specific patient. As Kazuo nicely mentioned, that we always need to take a balance between the potential coronary access in the future, post-TAVR, and avoiding the risk of conduction disturbance. So cusp overlap technique, enables to isolate the non-coronary cusp, and we can um, clearly see the depth on the, especially on the NCC side. So in this specific case, since the membranous septum was 5.5 millimeters, I guess we can aim to implant the depth of the valve at the NCC side around 3 to 4 millimeter depth in order to facilitate the coronary access. And in this specific case, we have used intracardiac echo, which visualized the membranous septum throughout the procedure. So we can adjust the depth accordingly by the image obtained by the ICE image. So please appreciate these images later.
Great comments. Didier, do we have any questions from the chat box so far?
So
Maybe not yet.
not yet, but relating to the case presentation, it's a part, maybe we're going to tackle that afterwards. The patient only had a CT coronary assessment, and we may have to discuss a bit later about the way to assess the coronary arteries. Do we go for a coronary angiogram, or can we rely on a CT alone? And what are the situation in which we have to either combine both or use a coronary catheterization systematically. So it could be interesting to tackle that if you want, Michael, maybe afterwards.
I guess we have
Okay,
one
maybe.
comment at the chat box.
Okay, go ahead. Can you?
Yeah, so the question was raised was the small anatomy would be a major challenge for future valve in valve. I guess it's a very important question. Dide, would you want to touch on this since you
Yeah,
have
so I think
experience in
that's
TAVI?
yeah, that's a very important comment, and it comes to the it relates to the sequence. What is the impact of the first valve choice if we have a young patient with a small anatomy? How do we envisage the valve in valve in the TAV in TAV in the future? So I would answer two ways, both ways. I would say that first, if we think that we are treating a very young patient, to my opinion, hemodynamics matters. So I would use a device that provides the larger EOA, the lower gradients, the lower rate of patient prosthesis mismatch, just to be sure that these patients remains quite active. So it would be for a small anatomy at first step as the initial procedure, index procedure, it will be a self-expanding supraannular platform, enabled Pro Plus. Maybe tailoring, as we have understood from you guys, the depth to be sure that we maintain the access to the coronary arteries. You're going to drive us through the cusp overlap technique step by step, UA. And as a second procedure, 10, 15 years after, maybe a short height stand frame device inside that Evolut platform would make sense. So self-expanding supraannular at first for the hemodynamics, keeping access to the coronary arteries. We're going to get the details on how to achieve that afterwards, and a short second TAVI device inside it when the first one fades. That would be my proposal.
Great, thank you, Didier. Kazu, maybe you can try to summarize our discussion, and then we can go directly to our recorded case.
Okay, thank you, Michael. So let's start the slide. So let's summary about the conduction disturbance after TAVR. So still the conduction disturbance after TAV implantation is a concerning issue, and the incidence of postoperative pacemaker implantation differs from the device type or the implantation technique, but it is still reported to be around 10% to 20%, even using the latest devices. And the new onset left bundle branch block is reported to be have much higher incidence, and some reports shows that the incidence will be more than 50% after the procedure. So how this conduction disturbance will impact on the clinical outcomes? So it is also the result is conflicting, but when we look at the meta-analysis, the new pacemaker implantation would have impact on the all-cause cardiac death, all-cause mortality in the 1 year, and the heart failure hospitalization. And when we talk about the new onset persistent left bundle branch block, it has a much more impact on the late outcomes, not only the all-cause death but also to the cardiac death and the heart failure hospitalization, and it will lead to our permanent pacemaker implantation. For avoiding this conduction abnormality, we have to recheck about the anatomy of the conductions. So it is well known that the atrioventricular conduction will penetrate the interventricular septum, and which will comes anterior and inferior portion of the membranous septum, which is located between the right coronary cusp and the non-coronary cusp. So making mechanical damage to this conduction would lead to a postoperative abnormality. So one key point would be the distance between the implantation depths and the length of the membranous septum. So this report shows that if the difference between the membranous septum and implantation depths goes more than 2 millimeters, the risk to develop postoperative conduction abnormality would be quite limited. On the other hand, when it comes very close, it will raise the risk for the abnormality. And other procedural factors, including the pre-existing right bundle branch block or left bundle branch block, will increase the risk of postoperative pacemaker implantation, and the amount of calcification, especially in the bottom of the non-coronary cusp, will be associated with a risk of coronary conduction disturbance. But what we can do is to avoid the low implantation depths, especially in the self-expanding device, which is usually not easy to control the implantation depths. But using the special technique, we can avoid the too deep implantation. And we have to minimize the depths according to the membranous septum for each patient. So if the patient has a long enough membranous septum, we can afford a little bit deep implantation. However, if the patient has a very short membranous septum, we have to make a very precise placement in a high position. So the cusp overlap view, as already discussed, would provide an excellent view to assess the implantation depth, especially for the non-coronary cusp site. And by using this technique, you can control the device depths efficiently, and we can reduce the risk for the postoperative conduction abnormalities. Thank you very much.
Okay, so welcome to Tokai University Hospital. Today we are going to perform transfemoral TAVI with self-expandable platform Evolut Pro Plus using cusp overlap technique. So this novel technique enables us to isolate non-coronary cusp. Therefore, we will be able to reproducibly implant the depth valve in a precise depth. This patient has quite unique feature that she has quite small sinus of Valsalva. Therefore, we are a little bit concerned of coronary obstruction after the valve implantation. So there's always a dilemma in this type of case that we want to implant slightly deeper in order to avoid coronary obstruction. Whereas in order to avoid conduction disturbance, we want to implant a little bit higher. So we are using images, intracardiac echo, to visualize membranous septum, and it will guide us the appropriate depth. Okay, so before beginning the procedure, I would like to introduce our heart team members. I'm Yohei Ono, interventional cardiologist, and on my right side, he's my buddy, Dr. Norihiko Kamioka, interventional cardiologist, Dr. Miyamoto, Dr. Saito, Dr. Shige-chan. And our head side, we have an interventional imager, Dr. Horinouchi, and dedicated anesthesiologist, Professor Kenji To. Just a classical perpendicular view. Looks good. Okay. looks more or less overlap. So we proceed. Pacing is rate 120. Inflate. Yo. 1, 2, 3, 4, 5. Okay. Deflate. Pacing down. The pre-dilatation was effective. Okay. So now we are advancing the Evolut system using the inline sheet. This is a 14 French equivalent system, and since this patient has small sinus of Valsalva, we need to take into account the after post-TAVR coronary access. So we will try to achieve commissure alignment in this patient. So let's see how it goes. So the direction of the catheter is important in this setting. As you can see, that we place the flush port at the 3 o'clock direction, away from the operator. So we will advance the catheter, the arch, pull the wire a little bit. Yep. Nice and smooth. Okay. So the image. So we can beautifully see how the hut marker goes via the outer curvature. So we will start implanting the valve. でいきましょうか。いいよ、OK。ペーシングまだいい。We will start the pacing once the valve is about to expand. So at this time, じゃあペーシング100。The pacing rate is 100. Let's go slowly. And we always take a small look at the ICE image, which the arrow shows the position of the membranous septum as well as the valve frame. The hemodynamics are very stable. Okay, looks nice, stable. いい感じですね。そろそろ撮影ですかね。Okay, let's take a shot here. 東照ゾーン Save the image. Nice. Looks good. Let's increase the pacing rate to 140. いいよ。行きましょう。Okay, pacing rate 100. Store the image. 東照ゾーン So at this point we will check the conduction, if there is a sign of AV block or not, and we have sinus rhythm with narrow QRS. Looks good. So let's see the ICE image. The frame, the valve frame is within the membranous septum, which is a good sign. Not bad. So this is the conventional three-cusp view, coplanar view, and we go to LAO in order to check the depth of the LCC side. So you can see the valve frames are very nicely aligned. So we can take a shot here. じゃあ撮影行きましょう。スペースありそうだな。So we can confirm that the valve frame is slightly under the annulus plane. So we would like to advance for the final deployment. So we will use this LAO view in order to release the valve. First, pull the wire in order to release the tension of the system. Okay, nice. Okay, じゃあゆっくり行きましょう。So after the confirmation of the two paddles completely detached from the system, we gently retrieve the system. Okay, the wire position is good. So the pressure gradient is almost gone. And diastolic pressure is well tolerated. Final gradient mean pressure rating is 6. Okay. So in this view, as we previously mentioned, we can accurately measure the depth of the frame, especially in the NCC side, which is around more or less 2 or 3 millimeters, as we aim to do so. So we can see how the valve frames are beautifully aligned in this original four-planar view. Okay.
Thank you, Yohei. So that's a great case. If I can make a short summary of how procedure refinements can improve the global TAVI outcomes, as illustrated by this case, I would say, first of all, for paravalvular leakage prevention, actually, with the device itself, there's an outer skirt which actually can prevent a lot more of the paravalvular leakage. And and then you saw the technique of cups overlap, so that you can allow us to have a high implant of the device, so that there's less interaction with the membranous septum, so that the conduction disturbances will be further minimized. And together with, if you choose a size not to oversize too much, that would actually facilitate the conduction disturbances reduction as well. Uh, in terms of the coronary access, I would say Yohi has shown you that in order to have a commissural alignment, a good commissural alignment, you have to align the flush port at 3 o'clock position. So with this commercial alignment with different devices, actually we can ensure future coronary access, especially when we move to the lower risk patients. There are certain anatomical factors which will also affect the outcomes of our patients, like the length of membranous septum or the amount of calcification of the annulus. These all will affect or increase the risk of with the short membranous septum. I mean, this will all increase the risk of conduction disturbances. But with such low risk patients, as we mentioned, this particular patient, although the annulus, although this sinus is small, but the risk score actually is not that high, and the FREL is not that high. So it's sort of like a low risk patient to us. So in that particular sense, durability will become a major issue in the long run if we are expecting a longer life expectancy. So Didier, can you talk to us about this durability and the longer life expectancy issue of our TAFI patients?
Yeah, sure. That's a very important issue, and it's really a contemporary question because we are treating patients with longer life expectancy. So we have to put into the equation the what we know about durability or valve deterioration in the future. So maybe we can see a couple of slides. If we only focus on the hemodynamic component of valve deterioration, the hemodynamic valve deterioration in randomized control trials patients were comparing TAVI to surgery, we can see that if we only consider the deterioration, increasing gradient or increasing regurgitation that we see within the devices, numerically we can see that it's a kind of double when we compare TAVI to surgery in terms of hemodynamic valve deterioration. TAVI seems to outperform surgery for this component at 5 years in randomized control trial patients. What we know from the literature, we still have to wait for longer data in terms of durability. We have to keep in mind that all the data that are available pertain to relate to high risk patients, elderly patients who most of the time don't survive their bioprosthesis. But we have this very excellent, nice data set from the randomized Notion trial up to that followed up the patient up to 8 years. So we have 8 years durability data. Notion was a comparison of surgery in low risk patients to TAVI with the core valve platform at the time of the trial when the trial was performed. And you can see that once again, in terms of structural valve deterioration, severe hemodynamic structural valve deterioration, when you combine a mean gradient over 20, or an increase more than 10 millimeters in mercury as compared to baseline, or more than moderate to severe regurgitation. Once again, TAVI is more efficient in terms of preventing structural valve deterioration. It's less frequent after TAVI as compared to surgery in this randomized trial on low-risk patients up to 8 years. And these are really reassuring data with this supraannular platform. When self-expanding supraannular platform, we have also reassuring data with balloon expandable platforms, but with less duration, less shorter follow-up. If we take another randomized trial, that is the TAVI trial, intermediate risk patients randomized between surgery and TAVI with the, once again, Evolute core valve platform. What we could see is that once again, up to 5 years, we have more structural valve deterioration in the surgical arm as compared to the transcatheter arm. So once again, a quite reassuring data set favoring the use of the TAVI devices, particularly the self-expanding supraannular platform, when it comes to either low risk or intermediate risk patients, up to 8 years if we refer to the Notion trial. But what we can say to be quite realistic is that up to 5 years, we have very reassuring data showing that the TAVI device that we use today seems to be durable at up to 5, potentially 8 years and beyond. We may discuss that, but we all have data about patients with longer durability of these platforms. And personally, I've seen patients up to more than 13, 14 years with a device that is still functioning. So reassuring data. But as we are treating younger patients, there is another issue that we need to bring into the equation is the issue of coronary access. And the OA has nicely demonstrated, and we may discuss that, how to promote further coronary cannulation with the cusp overlap technique and the commissural alignment. But sometimes we need to get access to these coronary arteries. And here are the data that are available, and if we take all the registries, what we can see is that on average, it's about between 2 and 3% of the patients who may require further coronary cannulation, and the duration, the time from the index procedure to the need for coronary cannulation, most of the time averages 2 years. So it's not as frequent. It's not immediately after the procedure, but it's something that we need to tackle. And this is the reality for all the TAVI platform that we are using today. Another reassuring aspect is that even though it's not 100% of the patients who have a very easy coronary cannulation, in close to 94% of the cases, we could get access to the coronary arteries. So it tells us that we still need some tips and tricks, maybe to be able to get an easy access to the coronary arteries, apart from some technology refinements in the future. But this is where we are. It's not a very frequent event, 2 to 3%. Success in coronary cannulation close to 95%. So we still need to discuss all together what to do with these remaining 5% patients. So I will stop there and open up the floor for discussion in terms of what do we do with this coronary issue. And potentially, maybe we could start with one of the questions that came up about the way to assess the coronary patency during the screening phase. Should we go for a coronary angiography systematically, or can we only rely on the information provided by the CT scan. And I would like to learn from you guys because you maybe you have more experience in that. And Yoe, as it was your patient, would you start with that?
Sure, Didier, thank you so much for your great summary and the question. So, in our daily clinical practice, we basically select not invasive angio, but we will evaluate the coronary trees with a CT scan. If the patient has quite calcified coronary arteries, we would consider invasive coronary angio. But otherwise, like shown in this specific patient, if the coronary trees are shown to be minimal calcium with patent coronary arteries, we basically don't go for invasive angio. That's our routine clinical practice.
Thank you very
Thank
much.
you,
And
Yohei. Yeah,
Michael,
that
yeah,
yeah,
I will hand over to you.
that's our practice as well. So we usually would assess the patient whether there are any symptoms of ischemic heart disease. If he has persistent on and off chest pain, which sometimes is difficult to differentiate from the severe AS. But if he's symptomatic in terms of ischemic symptoms, then probably we will go ahead with the invasive coronary angiogram. But otherwise, as a routine, we will do coronary CT coronary angiogram together with the CT angiogram at the same time. Look for amount of calcification. Look for coronary anomalies because sometimes with coronary anomalies, it would be very difficult to re-access the coronary artery after the TAVI device implantation. So if there's any doubt, if there's any stenotic lesions shown on CT, we will bring the patient for invasive coronary angiogram with a view to angioplasty, fix the lesion before the TAVI procedure.
And
Kazu,
Kazwo, do you have
what
the same
was your
experience?
practice?
Yes, I'm quite similar to both of you guys. So recently, the coronary CT provides very excellent coronary images, and almost every coronary lesion will be accessible with preoperative coronary CT. So we will screen the patient with a coronary CT, and if the patient has a suspicious disease part, we will go for the angiogram to assess for the further estimation.
So for us, for the
Uh,
time being, we are still doing the coronary angiogram. So it's a bit different because we are a bit concerned about the when you have calcium in the on the CT scans. Most of the time, it's quite difficult to really assess the presence of a narrowing of a significant disease below that, behind that. So we tend to do a coronary angiogram if the renal function of the patients enables that coronary angiogram, and just to understand the overall anatomy of the aortic root as a very first contact with the patient, and see if we have some proximal lesions that require a treatment. But as we are learning from a global, worldwide perspective, potentially learning from you guys, CT scan is going to be the default strategy for everyone, and select patients for a subsequent coronary angiogram only if we have any doubts on proximal significant coronary lesions. So there was Michael. There was one question coming from one of our friends, Shazad, about the Vive's choice in this small anatomy patient with a high risk of coronary obstruction. If could you summarize UA in a couple of words your Vive choice for this particular patient?
Thank you.
well, my valve choice,
Go ahead.
first of all, depends on the amount of calcium. If there's a too much calcium, with especially calcium extending to the left ventricular outflow tract, probably I would stick to a self-expanding device. And for small anatomy, if we want good hemodynamics, prevent patient prosthesis mismatch, you've mentioned, Didier, that probably I would choose a supraannular device so that to have the maximum hemodynamic effect. And if the coronary is really low, while we have to protect the coronary arteries, sometimes we might use a shorter framed balloon expandable device. Uh, but we have experience in using both balloon expandable and self-expandable device in these particular cases anyway. That's my usual ways to choose the different devices.
Okay.
So,
So
Kazu, can
I
I?
have questions. There are questions from the audience, and it was about your experience. We don't have any. We need to wait for a bigger registry on the really impact of the cusp overlap technique and the commissural alignment for coronary access. But the question is on our daily practice, how do we weight? What is the percentage of failure of coronary access with balloon expandable and self-expanding platform? Do you have the feeling that it's more or less the same? Do you have more difficulties with a self-expanding platform? And this could be a nice transition towards sharing some tips and tricks that we have for coronary access. So maybe Michael, you were about to ask Kazuo. Kazuo, do you have any estimation of the percentage of failure of coronary access, depending on the type of device that you use?
Yes, thank you for this is a very important question, and actually, as it mentioned, the Asian patient has more small anatomy compared to the Caucasian patient, so we have to evaluate our own patient, and we have conducted more than 200 cases to assess the post tower implantation coronary access, and it shows that. When we look at the easiness of the coronary access, it has a good tendency in the short frame self-expandable device. But so that would be the one issue in the small anatomy Japanese patient.
Okay, Michael.
Yeah, Didier, what we learned is that we actually have very high coronary reaccess rate for all types of valves, both balloon expandable, self-expanding device. Um, we actually test out in a web model with the supraannular self-expanding device. There are some tips and tricks. So as long as you want to have a proper good engagement of the coronary, usually you will have to downsize your catheter. Like if you used to engage the left main with the JL4, probably you will downsize it to JL 3.5, and on the right side, JL 3.5 sometimes. And the other tips and tricks is you try to use 035 guide wire, J wire, to direct the guiding catheter all the way to the coronary position. So you don't really engage only with the catheter itself. You go with the guide wire, and then you withdraw the guide wire and try to engage the coronary artery. But don't go below the coronary arteries and then pull back, because sometimes the native leaflet may actually obstruct your way of the engaging the coronary arteries. Um, of course, sometimes it depends very much on the commissural alignment. Usually, if you pay attention to the steps we mentioned about commissural alignment, you will have a good alignment and a very easy access of the coronary arteries. But in case the commissures are misaligned, sometimes you might need to like give injection from a far away place and then try to engage with a guide wire followed by an extension catheter so that you can actually engage the coronary artery better. That's our usual practice of engaging coronary arteries after the TAVI procedure.
Let me add
Any tips
one
and tricks?
small
Yeah, Yue? Please.
yeah, let me add some small comment, short comment. I would like to echo Michael's comment. Very important that we should downsize the size of the catheter. I totally agree with that. And we sometimes surprised that in patients with post-TAVR with 23 millimeter small size of evolute, we can sometimes engage left coronary artery with even Judkins right catheter, because the small type of Judkins right can enable us to access the left coronary. This could be a small tip to share with our colleagues. And for patients who will go for potential coronary intervention as chronic coronary syndrome, not ACS, I would strongly recommend to take the coronary CT scan in order to see the size of the valve, depth of the valve, and and on top of that, if the valve is commissurally aligned or not. That will facilitate the coronary access easier and faster.
And just to bounce on this comment, and I heard one day from one of our colleagues that referring to your idea of using the CT scan, we could do when we discover a patient with already a TAVI device inserted, and we need to get access to the coronary arteries, just to understand a bit in a quicker way the overall relationship between the device and the aortic root. What we can do is the root shot. You could start with a root shot first, just to see if the device is high, low, is commissurally well aligned or not, if the coronary arteries are very low, high, and so many things. So a quick root shot at the start of the procedure before trying to engage the coronary arteries may be very useful in some situations. And as we are about sharing tips and tricks, a very easy trick that I use just to be sure that we are central is that you try to cross the aortic, the TAVI device with a 0.035 wire, fold into the left ventricle with your guiding catheter, upsize, downsize as Michael has proposed, and then you start from the left ventricle and you go upwards, and then you use your wire just to get access, just to be sure that you are quite central. So there is one question that is not fully related to that topic, but maybe Kazuo, you could try to answer that. In case of LVOT classification, it's a question from Radek. Most of the time we said that we should use a self-expanding platform because of the risk of rupture and so on. But on the other hand, don't you think that sometimes we could use a balloon expandable platform with maybe less oversizing and taking advantage of the sealing properties of the skirt? What would be your recommendation? Is 100% self-expanding, or would you, in some situation, use a balloon expandable platform?
Yes, it is a very important question, and in our practice, we will definitely use the self-expanding device because the annulus rupture is our most severe complication in the TAVR, and the chance to rescue the patient is quite low. So we may have to accept some kind of regurgitation caused by the perivalvular leakage, and it will depend on the preoperative amount of regurgitation. So if the patient has no regurgitation at all, it will be very controversial. But if the patient has a mild or moderate preoperative AR, some amount of PBL would be acceptable. So we will definitely select the self-expandable device for the patient who have heavy calcium in the left ventricular outflow tract.
Great. Maybe my last question to Didier, very quick question. We all have patients survive more than 12, 13 years. But do you think, since you mentioned about durability, do you think we need more durability data so that we will be more comfortable to implant, to do TAVI for younger, lower risk patients?
So ideally, I would say yes, but realistically, I don't think that we're going to get that because we treated very elderly and high-risk patients in the past, and every single device has new iterations. What we know is that for instance, with the self-expanding supraannular platform, it's the same valvular design, the same function for years and years, and we already see patients approaching 15 years. So I don't think that it's a must having this durability data. What we need to work on, and that was one of the questions, is how do we sequence the type of device and the type of treatment that we apply for a particular patients, because we have very, very effective devices in terms of durability already. And just a quick word from the surgical literature, when we did the Viva Valve Valve trial, the median time for failure of the surgical devices was 9 years. 9 years. So we are really competitive with the TAVI platforms that we have already today.
Thank you. Yohi, maybe you would like to do a summary of today?
Sure. Okay. So I guess we're running out of time. So I would like to go quickly with a summarize of our discussion. Can we have the slides, please? Okay. So we've covered pretty nice topics about tips and tricks for coronary access after TAVI implantation. So first, I think it's important to know the device itself, the features, the size metrics of the Evolute, Sapien, and other transcatheter aortic valve device, as well as the root anatomy is especially important. And as Didier mentioned, we can see the overall overview of the device, how the TAVR device is implanted in the patient's root by just seeing the root shot. Or if you have time, we can also assess with a CT scan. We need to know how deep the valve was implanted and the direction. You mean the coronary, if the valve is aligned to the commissure or not. We cover the tips and tricks, which guiding catheter or diagnostic catheter to use. We tried to uh, s- select the smaller size of the catheter, and especially when we need intervention, the guide extension catheter would give a potential help for our procedure. So the point is very important if the valve is commissurally aligned or not. So we make this comment commissural alignment if the stent post of the transcatheter valve is far away from the ostium of the coronary arteries. And as shown in the left lower panel, each device has specific features in order to achieve this commissural alignment. Evolute Pro Plus, Accurate Neo, and Portico valve, which is now named Navitor. So as we showed the recorded case from our institution, the right-hand side CT scan is from the post-TAVI implantation CT scan that shows really nice commissural alignment. And as you can see from this slide, the coronary axis is feasible since the commissure post is far away from the ostium of the coronary artery. And we could nicely achieve this by implanting the valve, inserting this platform flush port on the 3 o'clock. And on top of that, we need to make sure that the hot marker is on the outer curvature at the descending aorta, through the arch, and to the ascending aorta. This is very important aspect. And for Asian patients, we have small aortic root anatomy as shown in this specific case. Compared to the Caucasian, we Asian patients have smaller sinus of Valsalva and shorter coronary height. So the device position, depth, commissural alignment is more especially important. So I'd like to thank you all for taking part in this webinar. It was my personal great pleasure and honor to take part in this program with all three experts. I guess in this 1 hour, we've covered very much important topics with educational message. And we would like to appreciate all the participants as well. And I would like to announce our next webinar, the fourth webinar of this series, coming up on the 2nd of November, which will cover the role of left atrial appendage closure for stroke prevention. Thank you so much for your participation. Bye-bye.
Thank you, guys.
Thank you. Bye bye.